All right, we're ready to go this afternoon. Welcome back from lunch, everyone. I think we're on virtually as well as everyone here present. Our next speaker, I'm proud to introduce. Mike's back for another year with us. Mike has been involved with respiratory and critical care for over 30 years. He is active in research, administration, teaching, and clinical practice. He has been awarded fellowships from the AARC and the SCCM. Mike has published many peer-reviewed abstracts, manuscripts, and textbook chapters. He is currently the Vice President of PM Serrana and Associates in Research at Duke University and Medical Center of Durham, North Carolina. And his presentation this afternoon is on Size Matters, Care of the Obese Patient. So let's welcome Mike Gentile, please.
Thank you, Candy. I wish I was there with you guys, but many things are preventing me from traveling over there today. I am located in the state right next to you in North Carolina. Thank you, everyone, for attending this, and thanks for the flexibility and all the scheduling. And hats off to all the people at Encore, and Zach and Colleen and Candy. I've been there, I think, 4 or 5 times during their 12. I think this is the 12th time they've done it. So they put on a great meeting. And so if you've never been behind the scenes of these meetings, it's like putting on 5 weddings simultaneously. There's always lots of things that can happen, but they do a great job. So today what I'd like to talk about is care of the obese patients. And this is a topic, area of research that I've been involved in for a number of years, and I will share what I've learned with you. I have no disclosures. I make all my own slides. This is all my own work. I don't have any related disclosures for this topic. What we're going to talk about this afternoon is we're going to talk about care of the obese patient. I'm going to give you a little bit of background. This is going to be everything I've learned the last 20 years, and you get it in 45 minutes or so. The physiologic effects of obesity, impact on clinical care, clinical strategies. Tonight, and if you get bored in your room and you want to look at something, you want to look up these topics on PubMed, you'll find care of the obese patient. There is 25,000 publications regarding this. Respiratory care of the obese patient, there's a little over 4,300. And polysomnography and obesity, there's only 25 papers. So I'm going to try and condense all that into one concise topic here for you this afternoon. What I want to do, though, is I want to spend a lot of time, just because I've been in this field for a while, is breaking down stereotypes and doing some education and get you guys a little bit of understanding of this patient population. So I think that's very important, because I've seen some very harsh things happen to these patients over time, and it's been sort of heartbreaking to see, but I'll sort of give you a little bit of education, and then hopefully you can move forward from here. So what is obesity? It's a chronic life-threatening condition, right? And so that's a very big statement. It's a chronic life-threatening condition. So it puts it up there with many, many other diseases. It's excessive body fat that often results in serious health issues. It's an independent risk factor for about 30 different health conditions. And we're gonna go into that a little bit more. It impacts medical, psychological, social, physical, and economic status. So that's it in a nutshell. So how we measure it? We measure obesity with body mass index. So if you look in your medical record, your BMI will probably be in there. I had mine done the other day, and I will tell you my BMI is 31, okay? So, and you don't have to do high-level math. Everybody who has a smartphone, there's an app or a medical app to calculate this. There's been some criticism of it because it does not account for muscle mass. You can see this lady right here has got a small BMI. She doesn't have much muscle. This guy right here has a lot of muscle mass, so his BMI is going to be high. to answer your question, I don't know if this is a real picture, but it's great to Google the internet and find these things, okay? So I don't think that's a real picture, but it's just to make a point. Degrees of obesity, and this has been around for a while, and there is many calls to have this changed. And, you know, normal is less than 25. At the other end, morbidly obese is greater than 40. And you all can look at and think about the highest and lowest number you've ever seen. Overweight and obese is where most people are, and then severely obese. And so there's efforts to sort of make this clear and condensed versus having obese, super obese, or morbidly obese, okay? But needless to say, it's kind of what we have to live with right now. The issues with obesity is here I am pushing a ventilator from point A to point B in the hospital. And at that time, my BMI was about 34. So the issues with BMI is you can see me, and I have a little bit less hair now, and I told you my current BMI, but the problem with BMI is it doesn't account for muscle mass. So tongue in cheek, there's another person who lives here close by who also had a BMI at the same time as me, and that's Michael Jordan. So I know how you guys get confused. My name's Michael, his name's Michael. We both played around ball. But what this shows you is there's problems with BMI. So, but you have to, this is what we have to use and live with. But some people want to do hip to waist ratio and other things. But right now we have BMI. Back to obesity, it's an epidemic. Remember, COVID's a pandemic. There's a difference between epidemic and pandemic. Obesity has been this slow burning fire for a while. And, you know, almost 70% of Americans, adult Americans, are obese or overweight. In the last 20 years, it's doubled, and 75% of children will become obese adults. And you can go to the beach or go to a school and see all this play out before your eyes. Now, what I'd like to do is show you where we were and how we got here. So this is a quick look at 1990, 1999, and 2009. And the darker colors means the higher incidence of obesity. And this is, the CDC has done this very well, and I'll show you this, okay? So close your eyes and take a trip back to 1985, right? What was life like back in 1985? We had maybe 10 channels on TV. Some of us still had party lines on the telephone. There was no such thing as the internet. There was no such thing as mobile phones. Computers were the space age things, right? So this is when this project started in 1985. And you can see that the lighter colors, and hopefully everybody knows where Tennessee is. And you can look at Tennessee or whatever state you want to look at. You can see it was 10 to 14. The white states weren't, the states in white there aren't reporting yet, but you can see how this happened. So get ready. We're going to go on a quick tour. There's 1990. You can see many states are reporting. And then you can see what happens is we jump up to a little bit higher colors, right? And you can see now that there's greater than 20%. In 1999, there's much more, right? And so we all thought the world was going to end in, you know, Y2K, but it didn't. So maybe people are stockpiling food. So then you see this is 25%. I'm not there with you. I wish I was, to get audience participation. Why in Mississippi and Alabama are there higher rates? In West Virginia, are there higher rates of obesity? The answer is because a lot of people stay close to where they were born and they're with their nuclear family. So what do we all get to, when we get together with our families, what do? We eat, right? And I can tell you my family's exactly the same. So you see 2004, 2005. Once again, you see the same states over and over and over again. Congratulations, Tennessee, you joined the 30% club, but don't worry, you're not alone. And you can see what happens is that's 2010. So us people in the obesity research world, we're all excited about this because we get this data. The problem with it is the CDC changed the way they gathered the data after 2010. So then they came up with a different system. I don't know why, and I would like to go back to the old system, but that's what we have. So 2011, it changes, and I think they couldn't tell that we all took geography in elementary school. They started to label the states. And you can see, once again, the states go up, and it's the same states over and over again. And it's the deep South, Alabama, Mississippi, and Louisiana. And if you've ever been to the states, they have great food, but a lot of cooking doesn't take place in the form of, nutrition conscious at times. Colorado is always the number one state to be less, and it's because it's very good climate, very active there. There are some people who joke that they legalize marijuana, so everybody's just eating Cheetos, but that's a whole nother joke. So you can see that as we go through time, 2019, and once again, we have 40% obesity, and you can see how it's spreading throughout the whole country. 2020, you can see how it goes up and down the Mississippi River, and then Texas and everything else. So that's the last year we have. We don't have 2021 data yet because it's not over, but these are estimates so far, and it's solidifying the data. However, the future looks even more bleak, because this is from another site which shows that there is less and less sites or states that there's lower obesity. It's not going down, it's actually going up. So it's certainly a public health problem that is here to stay, and we can go forward from there. It's also, many studies have looked at different ethnic groups, and non-whites who are either African American or Hispanic have more of a problem than people who are Caucasian. So this is held true over time. So what are the causes of obesity? It's multifactorial. It is truly multifactorial, and it's social class, diet, physical activity, environment, disease, disability, genetics, psychological behavior, puberty, pregnancy, and menopause. It's more of a struggle and challenge for women than men, birth weight, and rapid early gain. There's also other things such as availability of food, portion sizes in the US compared to the rest of the world. There's been several studies that show that our parents may not have had garages, and that they were more social with their neighbors. And garage doors actually have led to obesity, because people drive in their garage, they close their door, and they stay inside the rest of the time. There's also, on the right-hand side, you can see that's just a microscopic a view of fat cells. I thought was interesting. If you remember, 20, 30, 40 years ago, there was no such thing as computers. Now a lot of people have sedentary jobs where they spend all day on the computer. The poor economy and economic swings are a causative factor, but a lot of it is online use, because a lot of people spend a lot of time of their day sitting and getting screen time on Twitter, Facebook, and other ones, or other online media. And then if you have teenagers or even younger than teenagers, especially if they're boys, they play video games for hours on end rather than shooting hoops. So it's multifactorial, the causes of obesity. How does it look at a global perspective? Well, we're number one in this, and it's not a good place to be number one. And then you see other countries around the world, and part of it is genetics, part of it is culture, part of it is diet, part of it is do they walk a lot, part of it is work-life balance. So it's, once again, multifactorial. This is looking at diabetes, and this is diabetes around the world. And once again, it's a pandemic or an epidemic problem around the world. Diabetes goes hand in hand with obesity, even in places such as Africa. So it's a big consideration going forward to try and stem these. And it's interesting because places like Australia have less of a total population change, but there's still a significant increase there. So I always get the question, how does I was an ARDS guy for many, many years and involved in the ARSNet. And so how did I get involved in obesity research? I spent majority of my career at Duke University Medical Center in Durham, North Carolina. And so this is myself, and the other white coat is John Davies. And we're researchers in the medical intensive care unit. We got to host doctors from around the world. And these are our two doctors at this day. And they come for a year, they study with us. We do great research together, and then they go back to their countries. So this was their first day in the ICU. And their question was, why are your nurses so old? Because they were from Taiwan, and there they have a majority of young nurses. And they wanted to know why our patients were old and our patients were obese. So that began the research project. You can see there, I was not, they were all much thinner than I was. After they went home a year later, I got to go to Taiwan, and you can see that I was one of the thinnest ones there. So it was interesting because I asked him, why are your doctors so obese? But it was great because it was really the start of the hardcore research that several of us did at Duke, and I'll show you some of that in the next slide. So the two gentlemen you saw was Dr. Wang and Dr. Lin. And Dr. Lin was interested in patients in the cardiothoracic unit, those who came in for cardiac procedures and mainly, valves and cabbages and things like that. And so he took a big database of them, and he looked at them, and he found that patients who are obese come in with high white blood cell counts. They're on the ventilator longer. They're in the ICU longer. They have horrific and many complications, but they do not die. So what that means is healthcare dollars get stretched pretty far. So it was fascinating. And this study and this data has been replicated many times by many other investigators. Dr. Wang, on the other hand, was only interested in the medical intensive care unit, and he looked at 752 patients on mechanical ventilation over 3 years and found they had longer time on the mechanical ventilator, and BMI was an independent predictor of outcome in these patients. So it showed that it was a really significant thing to do. It also showed that it really mattered at both ends of the healthcare spectrum, whether it be surgical or medical. So we have to ask, is this a new problem? And the answer is no. And this is a cartoon. When you become an obesity researcher, people send you things. And so I've gotten lots of emails from people with cartoons such as this. So this shows the evolution of man. This is actual cover of the New York Magazine in 1932. I do not have the magazine, but I do have this picture of it, and this shows somebody stepping on a scale. So I thought that was interesting. So even in the 30s, it was a concern. Here is a Charles Dickens tale of a child who would eat himself full, and then he would fall asleep wherever he was. The name of that child was Pickwick, and that's how Pickwickian syndrome was named. So there's a lot of history to go with this problem, and I think it's actually fascinating to show where it's come from and where we are today. There have been many, many studies, long-term studies that have taken place in obesity, and here's looking at 5 decades. And this is men and women and baseline characteristics. And this is from 2007. And this is looking at men and women. You can see that for men, the BMI tripled over time, but the smoking rate also, was high in the 50s and went down. And it's the same for women, but not as great. It's more of a twofold increase. So as behaviors changed and culture changed, so did we traded one bad habit for another, if you will. And that's kind of where they are. And that's why people who are obese and smoke are at double risk for health issues. What about kids? This is something that someone sent me. I don't know if it's true or not. They said this is a billboard in Los Angeles where they have childhood obesity PSA notification with the McDonald's. billboard. And if you've ever seen the documentary Super Size Me, you know, it's all about McDonald's. Someone sent me a text this morning and said, today is the 50th birthday of the Egg McMuffin, and they were selling for 63 cents. And I guess the lines are wrapped around McDonald's. The American Heart Association is very concerned about this. They have many PSAs out there to try and fix childhood obesity or prevent childhood obesity. So it's a big public health concern. Kids, you know, a lot of schools have decreased sports. This is my daughter Claire when she was young. When we were staying in line at supermarkets, I would take pictures of her to sort of pass the time during long lines. And this picture represents eating a balanced diet, but the percentage of obesity in children has risen dramatically over this time too. About age, and this is another one, and this is recent data coming out from the CDC. And you can look across the top lines, the different colors represent different age groups from 20 to 60 and over. And you can see for total, there's very little difference. For men and women, there's very little difference. So people are living longer, but obesity is certainly a challenge. About healthcare. And this is what it's all about, is healthcare, because we're all in the business of testing, evaluating, and seeing these patients. The obesity impact is dramatic. This is a paper that has not been published yet, and you're seeing it here first. And you can see that this is a really great diagram showing it's not just the respiratory system that's impacted by obesity, but it's many systems that are impacted by obesity. And this should be coming out hopefully next week or next month in CHEST, so you can look for it. And it's looking at all the different systems. And that includes neurologic, pulmonary, gastrointestinal, endocrine, musculoskeletal, pharmacologic, and certainly dermatology, hematology, renal, cardiac, and then neck and everything else. So it's really quite a challenge, especially as the BMI goes up. Here's a more simplified look at it, and that is chronic conditions and also acute conditions. Those of you who are in the testing side, you know this. Those of you in the treatment side, you know this very well too, is these patients provide significant challenges for us all. So, but it is not just the respiratory system that it works on. It's a variety of things that are impacted. And the whole system, the whole body is connected, as you know. So let's dig down a little bit deeper into the OSA part. There was a recent review posted in Sleep Science, and this is good because it was sort of A to Z representation of obesity in OSA. And this is just looking at pathogenesis of cardiovascular disease secondary to OSA. So what happens during this time? So you have obesity, you have increased stimulation, and it's called WAT, white adipose tissue. And then you get a variety of different factors that are influenced, and you get immune response, and you get cytokines. Cytokines are these little minions that are not friends to the family or friends to the patient, and you get into a chronic inflammation state. And you saw that with our work from looking at patients who are obese and getting thoracic surgery, and you end up with cardiovascular disease. So it may not be just diet, there may be this inflammatory state that happens with these patients as well. So it's more of a molecular thing than anything else, but the molecular increased production of cytokines leads to cardiovascular disease. So what is the impact of obesity? And some people think these numbers are very conservative. There's, if you look at the top 10 things that kill people each year, it's, cancer, heart disease, COVID is in there somewhere, accidents in there somewhere, but there's a lot of people that die of this or related illnesses. And it's 10% of the healthcare costs, and there's billions, hundreds of billions of dollars spent on this. And there's been a 50% increase over the last decades or decade. Hospitalization rate is higher, and then mortality is higher. And you can think about your own practice and everything else. And you can see where medications, especially if the patient is a heavy drinker, heavy smoker, and has significant obesity, it's much higher. So let's look at healthcare providers. So this is a great study starting in 1976, and this is looking at nurses and looking at 120,000 nurses. And this is published in the New England Journal of Medicine in 2000, and I wish they would do something more. This is looking at 120,000 nurses for 16 years for BMI and risk of death. And it showed how as the BMI goes up, certainly the risk goes up. And you see, even from 20 to 35, the risk goes up. And there's a great correlation with waist circumference. Once again, some people are advocating for waist circumference. The lowest risk of death is high fiber diet, exercise, non-smoker, and moderate alcohol. So those of you who are attending the meeting, have a healthy snack this afternoon, go for a walk and have a drink and toast all of us for the last couple of years. So that's kind of the secret to health right there. I also think sleep is important as well. Getting enough sleep, because there's plenty of evidence about that too. So what about our T's? Any of you are budding researchers, I encourage you to do a similar study with respiratory therapists. And now everybody knows who respiratory therapists are, thanks to COVID and many other things. So this is a colleague of mine. I'm using this with his permission. His name's Anthony, and he got to be about a BMI of 50 in his highest weight. And then actually woke up one day in the ER because I think it was a combination of OSA and a little AFib, and it was a wake-up call to him, and he successfully lost weight over time. And so that was a great story, but nobody's really studied a lot of health behaviors of respiratory therapists, and I think it's well overdue. If you do it in your county, in your hospital, in your state, I think it'd be a pretty cool study, and it could get funded almost immediately. So what is our responsibility as healthcare providers for these folks? There's been a lot of conversation and controversy about healthcare providers talking to patients about their obesity, and then is it considered, harsh talk or an insult to talk to people about that? And there's medical schools don't teach us well, and neither do respiratory schools. And this, I like the top story or top headline, telling patients that are overweight or obese, an insult or effective intervention. And you can look at your own healthcare provider and ask them if they talk to you about any weight management, whether good, bad, or different. So what are the treatments? Well, the treatments certainly are, surgery. There's surgical interventions, and there's lots and lots of surgical interventions that are happening here. And the surgical interventions are bariatric surgery. If any of you work in that center, you see these folks all the time. And this just shows you the techniques that have changed over time. Here is the bariatric surgeons were very concerned if their patient who they had done surgery on got sent to the ER for any reason. So they published this great article telling the ER physicians, exactly what took place and how to manage these people. So it's kind of interesting to learn this technology or learn these interventions and see kind of what's happened over time, and also how practice has changed over time. What about equipment? We're all in a field where equipment is really sort of needed. And with this surge in obesity, there has been a great deal of change of equipment to handle these patients, from MRIs to ICU design that have lifts in them, because there was a lot of back injuries of staff having that happen. And there's ambulance services and specialized ambulance equipment to transport these patients as well. What about clinical care? So we have to look at these patients and say, what happens to them, and where can we intervene at what time? How can we test? And this is a sleep section that we're discussing today. So you guys know kind of what happens with these patients because you test them. But underneath just the apneas and the desaturations are these very significant things that happen to these patients. And this is all more looking at the cardiac side of things and what happens. And eventually they end up in heart failure for a variety of reasons. But this is a circle, or this is a diagram to show you how that all happens. So once again, this sleep review that was recently published has very easy to read diagrams that I thought were very helpful. And it goes to show you how this happens from not only something we can measure, but something we can't measure. And you see OSA is sort of at the beginning of this, and then how it all happens. And it's a vicious circle because they end up in heart failure, and then they end up with hypertension and apnea, and CO2 is going up and O2 is going down, and it's really quite a challenge. And a lot of it can be reversed by weight loss, and well, that is not easy. Many people find that to be an effective treatment. So the ventilatory response is really kind of interesting because we have increased resistance, decreased compliance, and all these volumes going up and down. Now, and then you have sleep apnea, and you have sleep deprivation, and all these things, and then the CO2 goes up. And as you know, this is a life-altering disease as well. Just OSA is certainly a life-altering disease. So it's fascinating to see how this all works together, and how all the things we learned in school and we never thought we'd use again, FRC and FVC and minute volume and expiratory reserve volume are all relevant to this discussion of obesity, sleep apnea, and certainly apnea and desaturation. And you guys are certainly pros at this, and you know that these are kind of the patients you see and the things you do every day. And it's also really important the CPAP issue, and the CPAP sort of issue has been clouded a little bit with recent recall, but it's certainly something that is really effective. And certainly my father has OSA, and he wears CPAP, and it's been very helpful for him. And it's always a blocked airway, and I don't know why that's such a cloudy picture, but you guys certainly are experts in this. I found this to be fascinating because it's always accused to be the male who is the snorer, the one who snores, and not the female. And we all know that there's a distribution there, but it's not always male who snore. This is a really good one because it shows more upper airway issues, and it also shows CT scans. Also talks about the drive and the work of breathing, and the lower respiratory drive as it affects the brain. And I can tell you obesity is similar to smoking where it affects the brain. And it's really kind of fascinating when you dig into the physiology of this and look at it for sleep patterns as well. And then you look at it from a lung perspective, and you think about ventilation, perfusion matching, and how some of these patients survive actually by sleeping in a chair and not laying flat or anything like that. So it's kind of fascinating to dig into the physiology. Lung volumes, we've already talked about lung volumes and showing how they change with obesity. I like this picture because it tells you what happens from beginning to end. And it's hypercapnia, which then leads to hypoxemia on these patients. And this was this was published by an Italian group in 2016. This is the rule of thumb for every unit increase in BMI, FRC decreases, PRV decreases. There's a decrease in all of them, including DLCO. DLCO decreases less. And so if we have patients with interstitial lung disease and also this obesity, then it's truly more of a challenge. Now, I paint a very harsh picture, but there's always hope, right? And we always hear patients who have asthma and obesity, and what happens is they have this altered smooth airway function, and this is a whole science within itself. And they have reduced airway diameter, not because of the bigger chest wall, but because of alterations to smooth muscle. And one of the first things they tell you when they lose weight is that they no longer need their inhaler. It's because they're changing their smooth muscle in their airway. So it's really interesting. And there's been recent publications, just some really good scientists have figured out how to measure fat cells in the airway. So that will be sort of the new things coming forward. Kind of reminder that even though the patient's the same height, if their weight is different, if they're the same gender, their weight is different, their lungs don't, their lung volume per se, especially when it comes to measuring tidal volume per mLs per predicted body weight, does not change. And this has been demonstrated a couple of times by some really cool CT scans showing here's a patient with 52 kilos, patient with 21 kilos. And it's interesting to look at the CT volumes. These are high-tech CTs, and showing how the lung volumes are close, even though the body is different. So if you think about all of our medications, many of it is delivered per actual body weight. Tidal volume in mLs per kilo predicted body weight stays the same, no matter what the patient weighs. It's all based on gender and height. Compliance certainly goes down as the BMI goes up. There's been a great deal of research in this, and this is Dr. Pelosi out of Italy, and he's the anesthesiologist. So when people came into the OR, he anesthetized them and did all kinds of great measurements. An easy way to think about this is the CT scans to the left, and you see the obese patient has a much bigger chest wall than the non-obese patient. So if you turn to the person to your right or to your left and look them in the eye and you think about incorporating their body weight into yours, that shows you how the chest wall changes, and that will be also how your compliance changes. Those of you who have children or dogs know that when they lay on top of you, it's kind of harder to breathe when you're laying on your back. Resistance the same way. Once again, I talked about the resistance of the airway and changing of the smooth muscle, and that changes over time. The less the BMI, the lower the resistance, and certainly work of breathing. Morbidly obese patients, you watch them breathe, and there's a lot of work that goes into that. What about atelectasis? We see this all the time. And this is hard to ascertain just because, nobody really quantifying atelectasis is difficult. It's just a general comment usually on a chest x-ray. And it's because they have hypoventilation syndrome and high chest walls. And you can see 24 hours after extubation, these patients have much more atelectasis than non-obese. Radiology is always a concern, and this is how atelectasis is judged and monitored. And certainly we need these radiology studies on patients to look for lines and abnormalities, but patient size really matters when you're trying to do radiology studies. Arterial blood gases, as we've shown before, this is looking at patients with bronchospasm, obese and non-obese, and these are patients. And interestingly, these patients had lower PO2s, and certainly those in bronchospasm had lower PO2s. The CO2s weren't as bad, except for if they were in bronchospasm. So once again, lung function goes hand in hand with obesity. Now, COVID it's even worse. The news is even worse. So this is recent data from the CDC. Again, BMI at the top. And then you can see the BMI slices down at the bottom. ICU admission goes up with BMI. Mechanical ventilation goes up. That's the third block. And death certainly goes up. So patients with high BMIs who enter the hospital and then go on IMV, go on mechanical ventilation, have a certainly increased risk of death compared to those of lower body mass index. We saw the same thing in H1N1. Remember H1N1, it was an easy pandemic that was localized in many places, but saw the same thing with that with obesity, and hopefully it all makes sense by now. For clinical strategies, well, interestingly, there's a couple things that happen. I think this needs to be used more at home because instead of CPAP, because compliance might go up. As you all know, compliance with CPAP is a challenge, and that's using a high flow nasal cannula because it's less restrictive than everything else. And here is a study, kids, there's 12 kids, they were average of 10 years old, they had an average of BMI of 35. And when they called it TNI at that time, and it's high flow nasal cannula. So they turned these patients on high flow nasal cannula, they provided just enough CPAP, and it stopped their apnea, and I thought it was a great idea. So I think this is something that can be utilized more, and we're seeing that because now you can do it off-site. CPAP and NPPV, it's used for OSA, hypoventilation syndrome, and in the hospital, it's used to avoid intubation and the complications of intubation, and also avoid the complications associated with mechanical ventilation. Airway management in these patients is a challenge, and it should be not entered into lightly because of the large neck circumference, the Mallampati score, which means how much of the vocal cords you can see, limited neck mobility, and then the mandible issues. There's many tools and equipment that have come out to aid in this, and I encourage people to use these and have a plan for the patient at all times. Positioning the patient is very important because letting these patients flat and expecting an easy intubation is a challenge. Lining them up properly, no matter what it takes to do, is important. And there are some commercial products that are helpful in this. Also, using things such as bronchoscopes have been helpful at times. But once again, it's really important. And some people even use high flow nasal cannula for these patients to help them stay stable during intubation. If the patient ends up on the ventilator, you treat them the same, but not quite the same. You still have to think about the lungs. They're still the same size lungs. And you have to use much higher PEEPs. And I'll talk about that in a second. Tide volume should be calculated on the basis of ideal body weight and not total body weight. You have to have the bed up and reverse Trendelenburg. And you will need NIV and high flow nasal cannula after extubation. Once again, this is Dr. Pelosi's data. I just like referring to it because it's so clean, and it just shows resistance, how it changes when you add PEEP to these patients. These are patients with normal lungs that are just there for an operation. So it's a very simple strategy to do. You add patients, or you add PEEP to them. Now, PEEP or CPAP is not used in the same way it would be for an ARDS patient. It's just to get the chest wall off the lungs so the lungs can function properly. A lot of it's studied in the pleural pressure, and this has been done many, many times. So the pleural pressure changes, and the pleural pressure is a great view of the lungs in these patients because you have battling forces of pleural pressure and abdominal pressure, and that's all translated to esophageal pressure. Perino out of Canada published this, and this is a patient who had esophageal balloon manometry, and this helped guide this patient. Of course, this was an N of 1, and they got real uncomfortable because they kept turning the PEEP up and nothing was happening. So using the mechanics of the lung and esophageal pressure, they went up to a PEEP of 22, and that usually makes many clinicians very nervous. And you can see here's a PEEP of 20, and all they're doing is using transpulmonary pressure, and you can see it's -4 there, and they went up to 22 and got better. What about body position? If you can move the patients around either side to side or better yet on their belly, you can then change the way the lung behaves. Prone positioning of obese patients is a team sport and should not be entered into lightly. Any dislodgement of any lines or tubes is catastrophic for these patients and all patients. So there's many guidelines for that. And it takes many more hands to adjust these patients than it does other patients, just because of the weight and the size, and everybody has to contribute. So there's many clinical practice guidelines for this and many papers to show how to do this safely, effectively, to help the patient, but also do it safely. I like this in one slide. This was just published last year, and it's basically when a patient comes in, I try to come up with different taglines for BMI to have people think, what do we need to do? And it's, I can't come up with anything, be more intelligent, be more intuitive, something like that, because you have to think about the disease, and then you have to think about, okay, what are we going to do as clinicians for these patients, and always be prepared for these patients. So today, the take-home points are obesity is a multifactorial epidemic. I mean, it's been going on for a while. It's going to continue to be here. We're going to see more and more of these patients in our hospitals and in the healthcare system, certainly for sleep testing and certainly treatment over time. And effective care for this population is based on physiology. It requires individual attention and care for these people because it's a multifactorial disease too. Education regarding health consequences by all clinicians can have a positive impact. That includes all of us in the room, and broaching that subject with the patient is certainly something that we can all do. It just takes a little bit of training and a little bit of conversation to do that. And obese patients come to the hospital, they stay longer, they have more complications, but they may not have higher mortality. And with that, I thank you for your attention, and I'll answer any questions. Are you all still there? Or did everybody fall asleep? Okay, if anybody has any questions, certainly Colleen and Candy know how to get in touch with me. I will gladly, I see. Chat. I think, all right.